Welcome, everyone. Today, we're going to explore some important concepts through multiple-choice questions. The focus will be on the basic level understanding of Mycobacterium tuberculosis. This is the first slide, so I just want to warmly welcome you all and give a quick overview. We'll be covering key facts about Mycobacterium tuberculosis, its characteristics, and some essential points to help you grasp the fundamentals. Let's get started and make this an engaging learning experience. Let's review the key diagnostic tools for tuberculosis. First, we have the chest X-ray, which is quite useful for detecting lung abnormalities associated with TB, but it doesn't specifically confirm the presence of the bacteria. Next is sputum smear microscopy, a quick and cost-effective method where we look for acid-fast bacilli under the microscope. It's widely used, especially in resource-limited settings, but it has limited sensitivity. Then there's culture on Lewinstein, Jensen medium, which is considered the gold standard. Although it takes longer, sometimes weeks, it provides definitive identification of Mycobacterium tuberculosis. Lastly, the Mantoux test, or tuberculin skin test, helps identify exposure or immune response, but doesn't distinguish between active and latent TB. So, when considering diagnostic accuracy and confirmation, the culture on Lewinstein, Jensen medium, remains the gold standard for diagnosing active tuberculosis. Now, let's talk about the culture on Lewinstein, Jensen medium. This is a specialized growth medium used primarily for cultivating mycobacteria, such as the bacteria responsible for tuberculosis. It's a solid medium that provides the nutrients necessary for these bacteria to grow while inhibiting the growth of contaminant organisms. The key points here are that Lewinstein, Jensen medium is selective, which means it helps us isolate mycobacteria from clinical samples. It contains ingredients like egg, glycerol, and salts, which support bacterial growth, as well as certain antibiotics that suppress other bacteria. When we culture on this medium, we're looking for characteristic colony appearances that can help us identify specific mycobacterial species. For example, Mycobacterium tuberculosis typically produces rough, buff-colored colonies. Understanding the culture characteristics on Lewinstein, Jensen medium is essential because it ties into the overall process of diagnosing and identifying tuberculosis, which is a major focus of this presentation. So, in essence, this slide reminds us that the culture method plays a crucial role in confirming the presence of mycobacteria, and the Lewinstein, Jensen medium remains a gold standard for this purpose. Let's take a closer look at the characteristic pathological lesions caused by Mycobacterium tuberculosis infection. First, we have the non-casating granuloma. This type of granuloma is characterized by a collection of immune cells that form without central necrosis, often seen in certain types of infections or inflammatory conditions. Next, we see the casating granuloma. This is perhaps the hallmark of tuberculosis. It features a central area of necrosis that looks cheese-like under the microscope, which is why it's called casating. It indicates a more aggressive immune response attempting to contain the bacteria. Then there's abscess formation. While abscesses can occur, they are less characteristic of TB compared to granulomas, and they involve pus-filled cavities resulting from tissue destruction. Lastly, sometimes we see fibrosis only. This indicates a healing or chronic phase, where the tissue has been replaced by scar tissue without active granuloma formation. Understanding these different lesions helps us recognize the body's response to TB and guides diagnosis and management. The casating granuloma, in particular, is a key feature that points strongly toward tuberculosis infection. Let's take a closer look at the casating granuloma. This type of granuloma is a hallmark feature, especially in infections like tuberculosis. The term casating refers to the characteristic cheese-like necrotic center that develops within the granuloma. This necrosis occurs because the immune response is so intense that it causes tissue death. Within these granulomas, you'll find a core of amorphous, granular material, which is the necrotic tissue, surrounded by a rim of immune cells like macrophages, epithelioid cells, and multinucleated giant cells. These structures represent the body's attempt to contain the infectious agent, essentially walling it off to prevent spread. Understanding the formation of caseating granulomas is crucial because it highlights the body's coordinated immune response and helps us identify the pathology involved in certain chronic infections. It also ties into the overall theme of how persistent pathogens can evade complete eradication, leading to these organized immune structures. Today, I want to talk about some of the key volunteer programs that support our fight against tuberculosis. These include Nikshay Mitra, Swasth Sanguinis, TB Mitra, and Aragia Sahyaks. Each of these initiatives plays a vital role in strengthening our healthcare system and ensuring better patient follow-up. Nikshay Mitra, for example, is a volunteer program that helps track and support TB patients throughout their treatment. Swasth Sanguinis focuses on community health workers who assist in early detection and awareness. TB Mitra and Aragia Sahyaks are similarly dedicated to bridging gaps between health services and the community, ensuring no patient is left behind. Now, in line with the overall goal of the National TB Elimination Program, Prime Minister Modi has made an important appeal. He has urged volunteers, these dedicated individuals, or what we can call the TB warriors, to adopt artificial intelligence tools. These tools are crucial for follow-up, helping us monitor patients more effectively and ensuring they complete their treatment successfully. By encouraging volunteers to use AI, we're harnessing technology to make our efforts more efficient and impactful. It's all about working smarter, not just harder, in our fight against TB. This integration of community volunteers and innovative tools is a key step toward achieving our vision of a TB-free India. Let's talk about Nikshay Mitra. This is a key initiative designed to support and strengthen the TB control efforts. Essentially, Nikshay Mitra connects donors and volunteers with TB patients who need assistance, whether it's financial help, nutritional support, or emotional encouragement. The idea is to create a community-driven approach, encouraging everyone to participate in the fight against TB. By involving individuals and organizations, we can ensure that patients receive the necessary support to complete their treatment successfully. This aligns perfectly with our overall goal of making TB care more accessible and compassionate. It's about building a partnership between the health system and the community to achieve better outcomes for patients. Now let's look at some common vaccines. We have A, DPT, which stands for diphtheria, pertussis, and tetanus. Then there's B, MMR, which protects against measles, mumps, and rubella. C is BCG, the Bacillus Comet-Guerin vaccine, primarily used for tuberculosis prevention. D is OPV, the oral polio vaccine, which helps protect against poliovirus. So the question here is, which of these vaccines is used specifically to prevent tuberculosis? The answer is BCG. It's the only vaccine among these that targets tuberculosis, which is a serious infectious disease affecting the lungs and other parts of the body. Understanding which vaccine is used for which disease helps us see how vaccination programs are tailored to prevent specific illnesses effectively. And in this case, BCG plays a crucial role in TB prevention, especially in countries where the disease is more prevalent. Let's take a closer look at some of the diagnostic tools we use in tuberculosis detection. First, we have the sputum AFB smear, which is useful for identifying active pulmonary TB by detecting acid-fast bacilli in sputum samples. Next is the chest X-ray, a non-invasive way to visualize lung involvement and look for typical TB patterns, especially in cases where the diagnosis isn't clear from symptoms alone. Then there's the interferon gamma release assay, or IGRA, which measures the immune response to TB antigens. This test is particularly helpful for detecting latent TB infection, since it can identify immune sensitization without requiring a chest X-ray or sputum sample. Lastly, the Ziehl-Neelsen staining is a specific staining technique used on sputum samples to visualize acid-fast bacteria under the microscope. Now, considering all these tests, the question is, which one is most useful for detecting latent tuberculosis infection? The answer is the IGRA. Unlike sputum smears or chest X-rays, which are more geared toward active disease, IGRA specifically detects immune responses indicative of latent infection. This makes it especially valuable in screening individuals who don't show symptoms but may still harbor the bacteria. So, in the context of our overall theme, early detection and prevention, using the right test like IGRA for latent TB is crucial for controlling the spread and initiating timely treatment. Now, let's move on to slide 10, which focuses on the interferon gamma release assay, or IGRA for short. This is a key diagnostic tool used to detect tuberculosis infection. Essentially, IGRA measures the immune system's response to specific TB bacteria. When someone has been exposed, their T cells release interferon gamma, and we can quantify this response in the lab. What makes IGRA particularly valuable is its specificity. Unlike the traditional tuberculin skin test, IGRA isn't affected by prior BCG vaccination, which helps reduce false positives. This is especially important in populations where BCG vaccination is common. In clinical practice, IGRA offers a convenient blood test that requires only one visit, making it more patient-friendly. It's useful for detecting latent TB infection, which is crucial for preventing the progression to active disease. So, understanding IGRA helps us better identify individuals who might benefit from preventive treatment, aligning with our overall goal of controlling and eventually eliminating TB. So let's focus on the key cell wall components listed here. We have peptidoglycan, lipopolysaccharide, mycolic acid, and teichoic acid. Each of these plays a crucial role in bacterial cell wall structure and function. Now, the question is, which one of these is responsible for acid fastness in Mycobacterium tuberculosis? The answer is mycolic acid. It's a long-chain fatty acid that forms a waxy, lipid-rich layer in the cell wall. This waxy layer is what gives Mycobacterium tuberculosis its characteristic acid fastness, meaning it can resist decolorization by acids during staining procedures. This feature is really important because it helps us identify these bacteria under the microscope and also contributes to their resilience and pathogenicity. Recognizing mycolic acid as the key component here ties into the larger theme of how bacterial cell wall structures influence their disease-causing ability and our diagnostic strategies. Now, let's turn our attention to mycolic acid. This is a fascinating component of the mycobacterial cell wall. What makes mycolic acids particularly important is their very long fatty acid chains, which contribute to the unique and complex structure of the cell wall. This structure is what makes mycobacteria especially resistant to many common antibiotics and environmental stresses. The presence of mycolic acids also explains why these bacteria are so hardy and difficult to eradicate. They form a waxy, lipid-rich barrier that not only protects the bacteria, but also influences their pathogenicity. Understanding mycolic acid is crucial because it's a key target in tuberculosis treatment. Many anti-tuberculosis drugs aim to interfere with the synthesis of these acids, weakening the bacteria's protective barrier. So, in the context of our overall discussion on mycobacterial survival strategies, mycolic acid stands out as a major factor that helps these organisms persist in hostile environments and within host defenses. Now, moving on to slide 13, let's look at the different diagnostic tests available for TB. We see 4 options here: A. ELISA, B. cBNAAT, also known as Gene Expert, C. Western blot, and D. PCR only. The key point here is to identify which of these tests is recommended as a rapid molecular test under India's National Tuberculosis Elimination Program, or NTEP. Among these options, cBNAAT or Gene Expert is the test that is specifically endorsed for rapid molecular detection of TB. It's highly valued because it can quickly identify the presence of TB bacteria and also detect drug resistance, particularly to rifampicin, which is crucial for timely treatment. In contrast, ELISA and Western blot are more commonly used for other infections or conditions, but they are not the preferred rapid molecular tests for TB diagnosis in India. PCR, while useful, is often more of a laboratory method and not the primary rapid test recommended under NTEP. So the most important takeaway here is that CBNAAT, or Gene Expert, is the rapid molecular test recommended under India's NTEP for diagnosing TB efficiently and accurately. This helps us in early detection and better management of TB cases across the country. The correct answer here is B, CBNAAT, also known as Gene Expert. This is a really important point because CBNAAT has become a game changer in rapid tuberculosis diagnosis. It's a molecular test that detects the presence of Mycobacterium tuberculosis DNA and also identifies rifampicin resistance, which is crucial for managing drug-resistant TB cases. The advantage of CBNAAT is its speed and accuracy. Results are available within a couple of hours, enabling us to start appropriate treatment promptly. This aligns well with our overall goal of early detection and effective management of TB cases, especially in resource-limited settings. So remember, when quick and reliable diagnosis is needed, CBNAAT is the preferred choice. Let's take a closer look at some of the key immune cells involved in fighting tuberculosis. First, B lymphocytes, or B cells, are crucial for producing antibodies. But in TB, their role is more supportive rather than directly containing the infection. Next, we have neutrophils, which are among the first responders to infection. They can attack bacteria directly, but their role in TB is complex and sometimes linked to tissue damage. Then there are CD4 plus T lymphocytes, often called helper T cells, and these are absolutely vital in controlling TB. They coordinate the immune response, activate macrophages, and help contain the bacteria effectively. Lastly, eosinophils are more involved in fighting parasitic infections and allergic responses, so their role in TB isn't primary. So, when we consider which immune cells play the most important role in containing TB, the highlight really goes to the CD4 plus T lymphocytes. They are essential because they orchestrate the immune response, activating other cells like macrophages to kill the bacteria. This is a key concept because it underscores why individuals with compromised CD4 plus T cell function, like those with HIV, are especially vulnerable to tuberculosis. Connecting this back to our overall theme, understanding these immune responses helps us grasp why certain immune deficiencies make TB more dangerous and guides us toward better treatments and vaccines. Now let's turn our attention to CD4 plus T lymphocytes, which are often called helper T cells. These cells play a crucial role in orchestrating the immune response. They don't directly attack pathogens, but instead, they coordinate other immune cells to do so effectively. CD4 plus T cells recognize specific antigens presented by antigen-presenting cells, or APCs, through their T cell receptors. Once activated, they secrete cytokines that influence the activity of B cells, cytotoxic T cells, macrophages, and other immune components. This ability to modulate the immune response makes CD4 plus T lymphocytes central players in immunity, especially in helping the body mount a targeted and efficient response against infections. Understanding their function is key to grasping how the immune system maintains balance, fighting off pathogens while avoiding overreaction that could harm the body itself. This highlights their importance not only in infection control, but also in immune regulation and even autoimmune conditions. Let's take a closer look at some of the key first-line anti-TB drugs. We have isoniazid, rifampicin, ethambutol, and streptomycin. These are the cornerstone medications used to treat tuberculosis effectively. Now, the question here is, which of these drugs is not considered a first-line agent? It's important to understand that the first-line drugs are chosen because of their proven efficacy, safety profile, and cost-effectiveness. Among these, streptomycin actually falls into a slightly different category. While it was historically used as a first-line drug, today it's often reserved for cases where the first-line drugs can't be used or in resistant strains. So, in this context, streptomycin is the correct answer. It's not typically classified as a first-line anti-TB drug anymore. Recognizing this helps us understand how treatment protocols evolve based on resistance patterns and clinical experience, which ties into the overall theme of optimizing TB management. Let's talk about streptomycin, which is a really important antibiotic in our arsenal against bacterial infections. It's actually one of the first antibiotics discovered that was effective against tuberculosis. What makes streptomycin particularly interesting is that it belongs to the aminoglycoside class of antibiotics. This medication works by binding to the bacterial 30S ribosomal subunit, which interferes with protein synthesis. As a result, it effectively kills the bacteria or stops their growth. One key point to remember is that while streptomycin is powerful, it also has some potential side effects, like ototoxicity and nephrotoxicity, so monitoring is essential during treatment. In the context of our overall discussion on antibiotics, streptomycin highlights how targeted mechanisms can be used to combat specific bacterial pathogens. Its discovery marked a significant milestone in antimicrobial therapy, especially for diseases like tuberculosis, where treatment options were limited at the time. So, why do we use combination therapy in tuberculosis treatment? Well, there are several key reasons. First, it helps to reduce drug toxicity. By using multiple drugs at lower doses, we can minimize the harmful side effects that might occur with higher doses of a single drug. Second, combination therapy increases the bacterial mutation rate, which might sound counterintuitive, but it actually helps us prevent the bacteria from developing resistance. When we attack the bacteria with different drugs simultaneously, it's much harder for them to adapt and survive. Third, it's crucial for preventing the development of drug resistance. If we rely on just one drug, the bacteria can quickly become resistant, making treatment much more difficult. Lastly, combination therapy can help shorten the incubation period, meaning the time it takes for symptoms to appear or for the bacteria to multiply is reduced, leading to faster disease control. Overall, these reasons highlight how combining drugs makes our treatment strategies more effective and sustainable. Now, let's talk about an essential aspect of antimicrobial therapy, preventing the development of drug resistance. This is a critical point because resistance can seriously undermine our treatment efforts. When bacteria or other pathogens are exposed to antibiotics or antivirals, they can sometimes adapt and become resistant. This makes future infections harder to treat and increases the risk of spread. To prevent this, it's important to use the right drug at the right dose for the right duration. Overuse or misuse of medications can accelerate resistance, so stewardship is key. Combining drugs when appropriate can also reduce the chance of resistance developing. Ultimately, our goal is to preserve the effectiveness of existing drugs so that they continue to save lives. This is a shared responsibility that involves careful prescribing, patient education, and ongoing research. By doing so, we can help ensure that these vital medications remain effective for future generations. This slide doesn't contain enough information. That's why we're moving to the next slide.